Hey, Kathy, can you hear us? Okay.
Well, it's 5:01, so let's call the Health and Human Services Board to order. Roll call, please.
Julie Medeiros. Okay. I'm sorry if I pronounced your name wrong.
No, it's right.
Dr. Anwar.
He is absent.
Lisa Lind.
Present.
Sean Anderson.
Present.
Kathy Leaf.
Present.
Dave Osnes. Present. Greg Telejohn.
Present.
Mike Barclough. Sorry.
Present.
Deb Lindemann.
Is there any dissension on approval of the minutes from Wednesday, February 15th? Anybody having questions, or if not, they'll stand approved? Hearing none, minutes are approved. Public comment? There's no public here. Business items, Health and Human Services, monthly financials.
Okay. So the financials are in your report, and they're on the board if you can read them. These are through February of 2023. Just a couple of things to bring up. So the 2022 numbers do continue to change. So if you compare them to what we had last month, the revenues have increased as we continue to get some of our final claims paid from CARS or through Spark. On one of the state revenues, if we look at February of last year compared to February of this year, it's the 43560 State Human Services Grant. That's primarily the 8521 Transportation Grant. That contract just got signed, so that money will be coming in any day. That's one where we get the funds right at the beginning of the year, and then we have the whole year to spend them. Where most of our other state funds, we incur the expense, we submit the claim, and then we get reimbursed for them. Just as note, as we continue to go through, you see a couple red items. Some of those are expenses that came up where we just didn't have a budget line, or being that it's the first of the year, we keyed in a wrong account number on a purchase order or something. So some of those were getting corrected and moving to the correct expense line. I'm going to scroll down if nobody has any questions on Health and Human Services. Then I'm going to go to the skilled nursing facility, and that is on page 23. So when we get to the skilled nursing facility, on this one, we did have additional expenses that posted in depreciation, especially on page 5, you can see that. That went up $125,000 compared to what it was last month. And then we had additional revenues that were posted that are not showing up at this point. So there's a process that has to run for those to be in there. But the campus as a whole, right now I'm showing is $114,197 to the good, compared to the negative $202,000 in this report. As far as current year, we continue to have a fairly stable census. They are still working to get staff hired, so if you look at our pool staff expenses, we're already at $104,000. And again, Sandy is working with HR and with others to try and get people hired so we can reduce that expense. Any questions for me regarding the financials? Okay, thank you.
Yes, it is. And we have Becky Kerr coming up to tell you all about CCS.
All right. Hi, I'll apologize in advance if I start coughing, because I seem to be having a coughing fit a minute ago. I just wanted to initially thank you for letting me come and tell you about CCS. That's how we shorten it, so it's not such a mouthful. We are kind of a unique service, so it's a really cool service too. So we can go to the, I don't know, next slide. All right, so here's our org chart. As you can see, there's myself as the administrator. We have a service director. We have 2 CCS supervisors. We have 1 BH supervisor that is split between CCS and CSP, and I'll talk a little bit about CSP later. And then we have a CCS project manager. We have 17 service facilitators under 2 of the supervisors. Our BH supervisor also supervises a couple of service facilitators. She also acts as a MHP within CCS, which is the mental health practitioner. And then we have, aside from that, we have 3 other MHPs within the program. Excuse me. So what is CCS? CCS, it's a voluntary program. That's a pretty important piece because it's not something that can be court-ordered. And it will definitely meet the court-ordered for like therapy-type services, but it's not something that can actually be court-ordered. It is voluntary. It's a mental health and substance use recovery program. It's really focused on what that person wants to do with their life, and then we try to help with that. So we put in supports related to their needs and their goals. We don't tell them what they have to work on. It is really recipient-driven. So CCS offers those recipients opportunities within the program to receive both traditional services as well as non-traditional services. And some of the non-traditional ones are listed there, the yoga, equine, employment skills, that sort of thing. All of those services, though, need to be evidence-based. So it's not like somebody could come in and say, oh, I want to contract and provide horseback riding for you. There has to be a skill there that they're teaching folks that are related to the coping mechanisms they'll need going forward in the future to be able to manage their substance use needs or their mental health needs. All right, we can go on. I'll let that go up. All right. Some of this I probably touched on a little bit, but it's a program that's personalized to the individual's wants and needs, directed by the recipient or family. In this case, too, CCS serves all ages. So I think that the youngest we've had in the program is right around 4, and then we can go up to whatever. And most of our our services, or the recipients within the program, they're about 2/3 of those are kids, and then about 1/3 of them are adults. But we are really recovery focused based on really looking at people's strengths, not focusing on the problems that they have. We're really looking at outcomes. So when they enroll into the program, we're always looking at how will we know when we've met your goals? We're always trying to work ourselves out of a job because ultimately CCS shouldn't be in someone's life forever. It really is intended to be episodic. So they come into the program, they learn the skills, they hopefully leave and maybe never come back to us. Sometimes with kids, you'll see those fluctuate in and out, sometimes with adults as well. But the goal is really to work ourselves out of a job so that they never need us again. This speaks to the intention of what CCS was intended to do. It's intended to assist individuals who are in need of care outside of inpatient settings, but who, if their needs are not treated, they could result in hospitalizations during times of crisis. We're really trying to reduce that impact of mental health and substance use, and the goal is really to obtain the best possible level of functioning, stability, and independence for this service recipients as they define it, not like what we would want, but what they feel is the best for their life. I added this piece in for you because DHS, and particularly the Division of Mental Health and Substance Abuse Services, really views CCS as a way to transform the system. We do some really cool things with being able to provide those non-traditional services that most programs cannot. Excuse me. So it is a really cool thing that Wisconsin is doing. They're kind of leading the way in that respect. So we can go on. So who is eligible? They have to be a county resident and they have to pass functional eligibility. So there's a state of Wisconsin functional screen test, not test, but a functional screen that we have to do to screen for eligibility. They have to have a mental health and or substance use diagnosis for that screen. If they don't have one of those diagnoses, they won't pass the screen. So they have to have that, and again, require more support than what traditional outpatient services would be. And they have to have Medicaid in the state of Wisconsin. And this talks a little bit about what services are covered. CCS, again, is meant to help with recovery. The program works to stabilize and address mental health and substance use concerns. And that includes like self-managing their physical health and social health, as well as meeting their basic needs. So we provide resources related to housing and education and work, and some of those services can also be part of our service array. And this talks a little bit about those different service arrays. Those people that are enrolled in CCS take control of their treatment and recovery. They work with a team, so within St. Clair County, they have a service facilitator assigned to them, as well as the mental health practitioner, and together they work to figure out what the person's needs are and really then implement services based on those needs that can support what their goals are. And so, like the services that you see up there, those are different things that we can do within CCS. I put this in there to give you kind of a feel for, or a sense for the recovery team, what that looks like. So the recipient is always at the core. They're always driving the program. We are there to support them. So you'll see, them at the core, and then all of the other kind of supports around them, substance abuse professionals, their informal supports, mental health professionals, peer specialists, various other service providers. It really is a holistic review for them and support. When they do a comp assessment, they're really looking at all those areas so that we can help them. So here's some of the advantages to providing CCS. CCS supports are more comprehensive and better integrated services for recipients. A lot of times just traditional talk therapy doesn't work for folks with mental health or substance use needs. So having the ability to do some non-traditional things really works. It's also really cool, I've heard it several times from some of our mental health therapists, that they'll work with a person and they've been doing that for a couple of years and they're not seeing much for progress. when they get involved in CCS, then they start seeing progress. And that's really cool because, you know, I know people too where traditional talk therapy isn't the only thing that would help them. So other alternatives definitely is helpful. This, again, our part of our treatment modality is we use a team effort or recovery teams to really support that person. We allow this, the advantage for CCS is always also allows counties and communities to be creative in developing services that recipients need. We have a coordination committee per our administrative rule, and we invite community participation on that. We have providers on that. We have people with lived experience on that committee, and then we have certainly county staff as well. So if any of you are interested in that, you certainly could be part of that committee. It offers a better continuum of services from youth to adult, certainly evidence-based.
When you say youth, what's the age level?
And any age, really, because like I said, the youngest we've worked with is 4. So the kids really have to be able, you know, like traditional therapy probably isn't going to work because they're not going to be talking, but they can do some play therapy and some of those things. And then some of the other things that we have, sometimes the equine, they have to be able to understand what's going on and implement changes. The other thing that we have internally that works sometimes with the littler kids is we have family-centered treatment within St. Croix County, and that we get referrals sometimes just for that specifically through CCS. And that's really focused on more working with the parents and keeping those children in their homes. Because the kids that we work with actually are considered SED, severely emotionally disabled, or disabilities. So we also, like I said, better continuum of care for those services, or for kids to youth, and then we can help too as kids transition from you know, being 16, 17, that young adult into adulthood. You know, a lot of times services, you turn 18 and things end. With CCS, as long as we can continue with the medical assistance, we can continue working with them, so we can help bridge that gap. Again, holistic, and we're cost effective because we are completely MA reimbursed. This is just the CCS map within the state of Wisconsin. We're in 70 counties in the state, and only counties and tribal nations can provide CCS.
Is there a meaning to the color code?
If you look, CCS is, you have to get the full funding, you have to either be part of a shared services model or a consortium. So that's what those color codes are. Like for instance, St. Croix County is green, and if you look where Barron and Eau Claire are green, we share services and resources with those 3. So we're in a shared services model. The blue up there, like around us, is a consortium. So those 9 counties work together. There's one certification within those 9 counties. So that's kind of what the color coding is. It gives you who those counties are working with. So some additional information, we have over 40 contracted providers within CCS. That number has certainly grown in the last couple of years. It seems like, you know, we get some in and then we'll have some that choose to end services with us. And honestly, there is no provider that I've had that has told us that they're ending because they're not happy with what we do. Honestly, we've hired a couple of our providers, so once they get hired by CCS, they can no longer provide services. And then some of them are just changing how their business model is. So overall, we honestly, I feel pretty fortunate that we're doing really well with our contracted providers. At the end of 2022, we had 143 recipients enrolled in the program. I looked today, we're at 149. That is higher than we've really ever been in this program, so our numbers continue to grow. We still, at any given time, we typically have at least around 30 people that are in what we call an outreach episode, which is time where we got to get the medical records to show the diagnoses. There's some different things, so it's kind of like pre-enrollment. We work very closely with other departments. Oh.
Yep.
One quick question.
Yep.
Is the 143 number spread across?
Could you use your mic?
I'm so sorry. Is the 143 number spread across the 3 counties, or is it just St. Croix County?
That's just St. Croix County.
Thank you.
Yeah. Yep, even though we work in a shared services model, our certification is separate. We have our own. And then, yeah, we don't share recipients across that. We just work with St. Croix County ones. Yep. So I said we work closely with other departments. We work really closely with behavioral health, with Shars Group. We also work really closely with children's services. And all of our service facilitators are actually cross-trained so that if they're working with a kiddo that needs children's long-term care waiver, our worker is doing both of those. So they're providing the CLTS case management as well as the CCS management. All right. So the next thing I'm going to touch on just briefly, because these two programs are a little bit newer to me. They just came under my oversight as of really early 2023. So the Community Support Program and Targeted Case Management. If you think of CCS on a continuum sort of, CCS is really trying to work with those people that don't have the chronic mental health issues, whereas the Community Support Program is on the other end. They work with more chronic. And CCS can be a step-down program for CSP. So it kind of made sense to move that under my oversight so we can have some continuity there. But CCS, or CSP, I got to get all these acronyms right. This program has been really successful. It's been around the state of Wisconsin for a long time, but it's really successful with those people with chronic mental illness. So those people that might be in and out of the hospital, you know, it's very targeted to certain diagnoses that qualify for that CSP program. But it has been very helpful in achieving a better quality of life for those folks. And again, within the CSP program, they're assigned a social worker, and that social worker helps kind of case manage what they need and support. And then we also have targeted case management, and that's used in a variety of areas, but it's really intended to hook people up with resources and tools so that they can meet their needs. It's, yeah, access and referral to various supports within the county. So that earlier when I touched on that BH supervisor that we have in CCS, this is her shown on that screen. She's the one shared between CCS and CSP. In the behavioral health side, she supervises the clinical coordinator, a 1.625 BH technician positions, and then the CSP, there's 2 CSP case managers. And then this, again, this talks about CSP being the most intensive program we have. And again, that same functional screen that we have to do in CCS, we also do in CSP. When they do that, it will let us know, because sometimes they're eligible for both programs and then people have a choice. But they do that same functional screen and it looks at all of those areas. And so we have a clinical coordinator that does the screens for the CSP side. Costs for CSP are billed to insurance as appropriate, and if the client doesn't have insurance or the ability to pay, then there's no cost to those folks. And those are some of the services that are provided within CSP. CSP is more of an older model, so it's more probably medical model based. And so they're going to be looking more at those traditional services to help with mental health, whereas CCS is more, includes both. And then there's the targeted case management. That can be, we have behavioral health technicians that do that, and they partner with the person and there's a comp assessment completed, a recovery plan. Those are typically, TCM is typically a year or less, so not intended to be long-term, and the scope is really that information referral and getting them hooked up with resources. And then much like for CSP, you know, graduating potentially to CCS as a step down, TCM is another option for a step down for CSP. Again, time limited, and then there's minimal costs with that. CSP is a much smaller program in the county. A lot of times when given the choice, people will pick the CCS program over CSP if they're eligible for both. And then CSP is a little bit more limited in that you have to work with the psychiatrist in CSP, and sometimes folks don't want to do that. So, but CSP has 18 enrolled, and then targeted case management through the behavioral health techs, there's 23 that they're working with. So that's it. Questions for me?
Any questions? Go ahead.
This is some really great information, and I really appreciate that. This is one program I think that St. Croix County should be very, very proud of.
Yeah.
And we are backing you and your entire staff 1,000%. You guys are doing a tremendous job.
Thank you.
Please pass on to everybody our thanks. Our hats are off to you.
I will. We have some great staff
Bet.
in both programs. Thank you.
Any other comments or questions? Bob?
Yeah, I'd just like to say that CCS is a behavioral health service that we provide. Yeah, it gets confusing when you have a division labeled behavioral health and a division labeled something else that does behavioral health. But it's all behavioral health. The nice thing about CCS, to me, is that it's an example of the evolution of behavioral health care in this country, nationally and globally, really, where we're, based on research and science, we're finding that there are better outcomes when you have person-driven treatment plans, when you have services that reach people in the community, where it's strengths-based instead of problem-based for the individual. Just thinking back in my own career when I started as an adolescent counselor in Iowa back in the 90s, I guess, what we did then was we had prescribed treatment plans that we would give kids. We'd say, here's your goals. Work on them, you know, without any input really from the kid. And it's just an example, and then it went for adults too. It's just an example of how we're starting to realize through science and outcomes that we see from behavioral health kinds of services, is that when you engage people at a place where they're able and willing to engage you in ways in which they're willing to engage you, it increases it improves the outcomes, I should say, for that person or family down the road. And it's just a really nice model that I think HHS as a whole is striving to try and emulate by having like these co-responders with law enforcement, by having case managers in the community that work with people in the community. Children's Services does a lot of this within the community, working with families and kids around behavioral health kinds of needs. And you know, if we can take the CCS model as successful as it is in Wisconsin and apply it to other areas of HHS, I think we'll be more engaging with the public, and I think we'll have better outcomes in the long run. So it's just, and Becky's done a really nice job over the past 3 years. We both started about the same time, and taking that program and really developing it and building it and reaching more people in our county and helping them. Really nice presentation. That's all I had to say. Thank you.
Thank you, and thank you, Becky. for-
One question.
Oh, yeah, go ahead.
Under the CSP, when you said that, you know, that the cost is billed to the insurance, but when there is none, who does pick up that cost? Where does that end up going if there's no insurance?
Well, let's
So
see.
basically, it feeds back into either tax levy or our basic county allocation. So some of our state funding that we get, there's like $1,500,000, that's basic county allocation.
Okay.
So that's one of the places where we can use the state funding to supplement that. The other piece is TCM, CSP, crisis intervention, and the outpatient are part of our Wisconsin Medicaid cost reporting. So the cost for those programs feed into that cost report, so we get some of that WMCR money back that helps to supplement that. So we get medical assistance funding up front, but then the cost report and the basic county allocation help to support that. And then there's always some tax levy that probably feeds into that program as well.
Okay, so it's sustainable.
Yeah, and again, as you said, those chronically mentally ill, those are our people who are going to hit the emergency detentions. They're going to hit those hospitalizations. So if we can provide those services to them in the community to prevent those higher expenses,
It'll be a
it's
little
less
cheaper.
tax levy than it could have been otherwise.
Yeah.
Very good. Thank you.
It sounds complicated.
Yeah, it is. That's true.
Understatement of the night. Thank you, thank you. Anything else? Moving on. Review of services provided by the Comprehensive Community Services Division.
And I can kind of review this with Becky here. Becky has to stay here. It's a fairly simple review tonight because CCS, while it's not a mandated service, it's all Medicaid funded. So if, and Becky has described what the service is, and obviously just had the orientation. But since it's all Medicaid funded, if you were to reduce if you were to reduce the amount of services that we offered, you'd reduce the expense, but you'd also reduce the revenue by in equal parts. So you're not saving anything if you were to look at cutting CCS services to anyone. Beyond that, let's see. I don't have anything beyond that. It's pretty simple and straightforward, I think, unless you have questions.
The only thing I would add is that because CCS does have the Medicaid funding, it also has to be prescribed by either a psychiatrist or a doctor to say it's medically necessary. And then because we have our mental health practitioners on cases too, they also have to direct the services to be medically necessary given the symptoms or the issues that the person has. So it is driven by medical necessity.
Any questions on that? Oh, okay. Now we'll have the updates of the director.
Thank you, Mr. Chair. Yes, this month I thought I would actually provide updates instead of 500,000 announcements. I wanted to touch on just the things that I thought you might be interested in knowing that we're involved with. So the first thing is the strategic planning that HHS is involved in. We had our first strategic planning session through the University of Wisconsin Extension Office. Carrie Weiss and Selena Freemark are facilitating these. These are opportunities for us as a department to take the county strategic plan and look at those areas within the county plan that involve HHS, right? So we're looking at those specific goals and objectives that were in the county plan and then developing those more within our department. It also gives us a chance as a department to clarify our vision for the next 5 years or so. And some of that work was done in that first strategic planning session, where our vision came into focus a bit as we talked about what it is we want to become, not necessarily what we are today. We have 2 more sessions scheduled in coming weeks. We have them every other week now into April. And when that plan is fully complete, and once UW Extension has provided us with a nice product to show you, we'll bring it here and show you what we came up with for our strategic plan. A lot of it has to do with integration of service areas. A lot of it has to do with growth and expansion, partnerships with other county departments like Justice Support Services, Sheriff's Office, et cetera. So anyway, I'll wait until we have the final product to show you to see where we landed with that. Just a quick update legislatively. I went to Chair Telejohn, Supervisor Osnes, Supervisor Fiedler, and Supervisor Hanson. We all went to the legislative conference that the Wisconsin Counties Association puts on in Madison. It was the end of February, first part of March. Now, day one was sort of a lifting of spirits, and here's some promising things for counties to look forward to. And day 2 was sort of letting the air out of the balloon a little bit as the reality sunk in as to how all of this has to work out between the legislature and the governor's budget. But I think there's some promise there in terms of priorities that the WCA and that our county has with respect to human service legislation that we think would be helpful. Again, some of this has to do with partnerships with law enforcement and partnerships, or efforts, I should say, to move upstream of crisis situations and provide those early intervention kinds of crisis services to prevent hospitalizations, to prevent jail and other high-cost, poor outcome environments for people. We talked to our legislators, that is our legislative team here in St. Croix County, talked to our legislators about some of our ideas, about some of the priorities put forth in the WCA budget. One thing that I wanted to mention here was, it kind of ties in with the discussion about CCS, is that a couple of years ago in the last biennial budget, around that time, I put forward a resolution to HHS around Medicaid expansion and in support of that. And the resolution passed, but it was just it was a support statement, right? The reason I see Medicaid expansion is very beneficial for the populations that we serve in HHS, one reason, is that it increases the eligibility for Medicaid to 138% of poverty instead of 100% of poverty. What you're getting then is you're starting to reach people that are maybe working and they're not eligible for Medicaid. They make too much money for that, but they don't make enough money to pay for health insurance, or they don't make enough money to cover the deductibles to get things like substance use treatment or mental health treatment or other kinds of health care. Through Medicaid expansion, and something I talked to the legislators about a little bit was, even though it's not likely to pass, is that it increases our ability to serve those people in programs like CCS where we could serve them. Otherwise, those folks are still getting health care, they're still getting treatment, but they're getting it in emergency departments, they're getting it in crisis centers, places that cost at least twice as much, probably 3 or 4 times as much, maybe more than that, than the kinds of services that we could offer them. And their outcomes are often poor. So that, I mentioned it in the director's report because I wanted to emphasize my rationale for supporting this. It goes beyond that, but that's one aspect of Medicaid expansion where I see Wisconsin as a state that hasn't joined that could benefit. It might be just me expressing myself because I don't think that it's going to pass the legislature this year. We had a foster care event, moving on. We had a foster care event on, what day was it? The 9th, I think, of March. The 9th of March at the New Richmond Middle School. This was a recruiting event for foster parents. The guest speaker was Galen Elmore, who he's a football player. He's more than a football player, but he's a speaker on behalf of his own. He gives his own account of his own experiences in foster care growing up, a very compelling speaker. And we had a pretty good turnout. It was a snowstorm, of course, because there's one every other day, but it might have hindered attendance a little bit. But in talking with Dawn Campbell, who was with our Children's Services Division, who hosted the event or was the MC, she said afterwards they had about 7 or 8 interested parents who wanted to become foster parents. So it was might have been a smaller turnout, but I think the people that showed up were really motivated to want to do this kind of work. So maybe we'll have some good results from that. And Dawn said, or Michelle and Dawn said that Galen may be willing to come back and speak again. We funded this particular event in part. St. Croix County funded a part of it through ARPA funding that we had set aside for community partner organizations. So we were able to use some of that money towards this recruiting event. Quickly, the public health emergency, the federal public health emergency, is ending on May 11th. That has implications for people who are currently on Medicaid or who currently qualify for Medicaid and food share benefits, who maybe won't qualify after this public health emergency ends. And that's because during the public health emergency for the last 3 years, people could not be disenrolled from their Medicaid or food share benefits during the emergency. Now that that's ending, our Economic Support Division, the Great Rivers Consortium, all across the state, they have to review everyone's eligibility. Again, that's on their enrollment list. So some of those folks are not going to qualify for their benefits, and they're going to lose their health care and or food share benefits. As in response to that, our Economic Supports Division is working closely with the state and with our local partners to try and help people that will be losing their benefits find alternatives, find other sources of support for food and health care. We're considering and looking at options for how we could use the balance or the remainder of our ARPA funding in that community partner support program code to support, provide some financial assistance to food banks, to maybe the free med clinic, and use some of the money to help them with supplies and food costs, since there'll be an increased demand likely for those kinds of things. We haven't finalized agreements yet or anything, but that's what we're looking at doing. I talked a little bit about our substance use disorder services. If you remember, toward the end of last year, we had some staff leave or went on leave, approved leave at the same time. There didn't seem to be a theme there. There didn't seem to be a common reason why people were leaving. They took other jobs or they had a baby. But it left us short-staffed in that area for a period of time. And now we're just about fully staffed again. I think we have one position open. Is that right? We have one position open as a substance use counselor that's posted, and we're trying to recruit for. During that period of time where we were short-staffed, we looked at a reduced menu of options for what we could provide realistically with the staff that we had without overburdening them to the point where they just couldn't do their jobs. Part of what we wanted to do during this time where we were short-staffed was kind of constrict a little bit, look at the wait list and look at other priority items, persons who are maybe IV drug users, pregnant women, and that priority population, and focus on them during that time. So as we ramp back up here to almost being fully staffed, we can start to relax a little bit in terms of what we were previously not doing or not doing as much of. The drug court, treatment court I should say, has opted to go with Programs for Change as their treatment providers, so they've made that transition, and we're trying to help our clients, any clients that might have to make that transition with them, make it as in as planful way as possible with a warm handoff. We're planning our second mental health symposium on May 17th. That will be the same day as the HHS board meeting, so that will be the only item on the only agenda item on the HHS board meeting for May. That'll be held at Northwood Technical College from 5:30 to 7:30 that evening. We're still defining the agenda for that program, but it's going to focus on addiction. Again, with an emphasis on looking at addiction as a healthcare concern, as a chronic illness that's treatable, and get some different perspectives, looking more at the hope and recovery aspect of it rather than the gloom and doom of here's the problem that's terrible. We recognize that, but we want to focus the symposium on what can we do about it and how do we change or adapt our treatment and healthcare system to better manage chronic disease like addiction. And then the last thing that's kind of cool here is the Recovering Together Cafe. That is a new venture in partnership with Family Resource Center, where we sent some of our staff and some of Family Resource Center staff to a training. It's an evidence-based training on how to have these parent cafes where the groups of parents getting together are facilitated by another parent, a parent who's gone through this training on issues like substance use and on issues like addiction. These are typically families with young kids up to kindergarten age, parents with kids up to that age who might have either a personal concern or know somebody who has a struggle with addiction. And these groups are a curriculum that's intended to help those parents in that area through a progression of a series of parent cafes that will be held at the Services Center once a month, facilitated again by a parent with a professional co-facilitator there who doesn't step into the lead. They're just there for technical more subject matter expertise. But it's kind of a neat thing, and the reason this is exciting, beyond helping some parents and their young kids, is that we provide, or Family Resource Center will provide childcare, we'll provide a meal, we'll have incentives for the parents and families. We're paying for this through that same program code of ARPA funding for community partner organizations. For St. Croix County, we got interest through Pierce County and Polk County, so they're also doing these. They're paying for their own, but they're also doing these in conjunction with Family Resource Center. So it's a regional effort that hopefully will help some parents and families avoid getting involved with CPS or any other formal county service. It's voluntary. There's no formal connection to any of our service areas. It's simply meant to add a layer of support for families in our area who might benefit from it. Those will be starting on April 21st, a Friday, from 9 to 10:30 at the Services Center. Anybody's welcome to come. I think the registration process goes through Family Resource Center, so we'll put something on our website that helps people find that. And I don't think I have anything else, unless you have questions for me.
Any questions? Sean?
So, is the reason that treatment court ended the relationship with the county behavioral health services, was it due to the staff shortage? Was it clear it was temporary? How many positions are allocated to serving that role?
Yeah, it's a good question. We were very clear this was a temporary staffing issue. I don't know specifically what the other reasons were beyond that for the court deciding to go this direction. I know that they were concerned about our ability to provide intensive outpatient treatment, which is a level of care that I know the courts wanted us to provide. We do provide that, but not in the same way that I think the courts wanted us to. And we went through, there was a rule change last fall for this area, this service area, that required us to apply for certain certifications, and we're waiting on the state to provide us with one of those certifications, which was for the intensive outpatient license or certification. But essentially, we could provide all of the care that we did before with a temporary pause on admissions. So I think there was another part to your question that I'm not sure I answered.
Yeah, how many, I guess,
Yeah, staff.
staff, yeah.
Yeah. Was there one?
One who provides that, but not full-time.
One staff that worked with the treatment court, but not full-time. Correct, okay. So that person would then be reassigned to other duties within the addiction area, which we could use the help with anyway, so it worked out.
Any other questions? Thank you.
Sure.
Requests for future agenda items. Just to let you know, it's going to be mandatory that you go to the May 17th mental health. No, it won't be mandatory. But that will be our meeting, essentially, on May 17th at Northwoods. So put that on your calendar. You won't have to drive to Hudson.
Yeah, it's basically on my way back.
Yeah.
At the same time?
5:30. You even get an extra half hour. So, any other agenda items for next month? Any other? No? Announcements or correspondence?
Mr. Chair, I was just going to address one of the future agenda items from last month was for the Public Health Department to provide an update on the Community Health Improvement Plan. And I spoke with Kelly Engen, our health officer, who said they're very happy to do that, but she's waiting for some additional developments with that plan that will come through in April, so she'd have more data and more things to report on. So just to address that's something that we're happy to do. It's just the timing of it. With the symposium coming up, that it might be
And
delayed.
I'm waiting to get confirmation from Westcap on their homeless program. And everybody's so busy there, it's been hard to pin down the schedule, so still working on that for future. Anything else? Any other announcements, correspondence? No. I guess that's it. We're adjourned at 5:49.